Broadly speaking, I would say there's two categories. One is if a provider has a relatively straightforward question about development or behavior, and they'd like some quick input from a developmental behavioral pediatrician, ideas about local behavioral resources, developmental resources, or social services, or if they have a question about relatively straightforward medication management around such things as ADHD or sleep, question on help around an elimination disorder. That would be kind of one category. And the other major category would be if a patient really has higher level of need and the provider is planning or has referred the child or adolescent to the CDRC, but the wait list is long and the provider would like to get some help in the meantime, it makes a lot of sense that to go ahead and place that referral, but also call us at OPAL-K DBP to get some input for the child while the child waits on the wait list. So again, I think sometimes the referral's completely appropriate, but the wait is just too long, and so there are missed opportunities as the child waits for even a year or more for an assessment at CDRC. So OPAL-K DBP can be a way to explore ways that the child could get services in their local community with their local mental health services or social services or developmental supports while they wait. Often children could already get help. Sometimes kids have a diagnosis from another state or have a diagnosis from another provider, and it's just a matter of moving forward and accessing some of these services which the child already qualifies for. And so we like to expedite kids getting the help they need, point the provider in the general right direction while we wait for maybe refining referrals when we see the child in a year. So far, we've done about 80 calls personally, and they break into groups such as I mentioned, kids that are waiting for a consultation. We can get some help going, more straightforward needs. Also, we have some kids that we've seen and have very complex care coordination needs. So we can use OPAL-K DBP as an opportunity to make sure that the referrals happen, care coordination occurs. Or we have kids transitioning towards adult services, and we can use OPAL-K DBP to inform an internist or a family doctor who's assuming care for a young adult to give them some background on this complex young adult that they're receiving into their care. Well, as I've already mentioned a few times, the wait list is excessive, and it has been for a while. With the pandemic, the needs have increased, and also the awareness of needs has increased. There's been more adolescent self-referral. OPAL-K has identified a need to meet the needs of younger children that child and adolescent psychiatrists may not spend as much time working with the really little kids, toddlers, babies, preschoolers. And so for all those reasons, OPAL-K DBP has been developed as a way to meet the needs of these younger kids or kids who have intellectual or developmental disabilities or autism, or when those diagnoses might be suspected, to get prompt service and some prompt guidance, either instead of a referral or while kids are waiting for that referral to actually lead to an appointment. One other thing that can be done is we have large full-day diagnostic teams. Not every child needs the full-day diagnostic team. So sometimes what we can do with these calls is refine the referral and convert a blanket full child development team referral into a more specific diagnostic team, either a mini team or even a solo provider. We have feeding team, we have a neurodevelopmental team. So sometimes we can use the OPAL-K call to make a more appropriate, kind of triage it into a more appropriate place for clinic.